Welcome back to the integumentary system. In Lecture 1, we built the anatomy and physiology of the skin, the three layers, the accessory structures, how the skin changes across the lifespan. Today, in Lecture 2, we turn to what goes wrong and what we do about it. We'll cover three things. First, pathophysiology, common skin conditions you will see constantly in practice: dermatitis, acne, pressure injuries, and cellulitis, plus the three main skin cancers: basal cell carcinoma, squamous cell carcinoma, and melanoma. Second, diagnostics, how we assess and document skin problems, measure wounds, collect specimens for culture, and support biopsy. And third, pharmacology, the main classes of medications used to treat skin conditions, along with the common trade and generic names you'll recognize on a medication list. Throughout, keep tying what you see back to the anatomy from last lecture. When we talk about how deep a pressure injury goes or which skin layer cellulitis infects, you'll be using the epidermis, dermis, hypodermis framework we already built. Here's the roadmap for today through 6 outcomes. First, describe the pathophysiology, the underlying disease process of our 4 common conditions: dermatitis, acne, pressure injuries, and cellulitis. Second, recognize the 3 main skin cancers: basal cell carcinoma, squamous cell carcinoma, and melanoma. And learn the ABCDE checklist for spotting a suspicious mole. Third, stage a pressure injury and, just as importantly, recognize the warning signs that mean you need to escalate to the provider right away. Fourth, explain the core diagnostics for skin problems: a good visual assessment, accurate wound measurement, skin culture for infections, and biopsy for suspected cancer. Fifth, identify the main medication classes for the skin: steroids, antibiotics, antifungals, and acne agents, and match up the common trade names with their generic names because you'll see both on charts. And sixth, as always, connect all of it to your role as a medical assistant. You are often the person who spots the problem, documents it, measures it, collects the specimen, and educates the patient. Keep these goals in mind. The summary will return to them. Here are the medical terms that you need to know to understand this lesson fully. Take a moment to look them over. We'll use each of them as they come up in the slides ahead, so don't worry about memorizing the definitions right now. Just get familiar with the words. Pause the video and take as much time as you need to take notes. Before we take the conditions one at a time, here's the roadmap. And notice how each one maps back to the anatomy on the right. Dermatitis is surface inflammation. It lives mostly in the epidermis and upper dermis. Acne is a disease of the pilosebaceous unit, the hair follicle and its attached oil gland, which sits down in the dermis. Pressure injuries are defined by depth. They start at the surface and, in the worst cases, extend all the way through the dermis and subcutaneous fat down to muscle and bone. Cellulitis is a bacterial infection that spreads through the deeper dermis and subcutaneous tissue. And the fifth item, skin cancer, is a malignant overgrowth of skin cells, most often triggered by UV damage to cell DNA. It usually begins in the epidermis, in the basal cells, the keratinocytes or the melanocytes, which is exactly why sun exposure matters so much. We'll give skin cancer its own slide because it's the most important thing on this list to catch early. So the anatomy from Lecture 1 isn't behind us. It's the map we use to locate and stage every one of these problems. Keep this cross-section in mind as we go. The layer a condition affects tells you a lot about how serious it is and how we treat it. Our first condition is dermatitis, which simply means inflammation of the skin. You'll also hear it called eczema. The hallmark is an itchy, red, inflamed rash, and it's one of the most common reasons patients come in for a skin complaint. The two cards on the right show the two forms of contact dermatitis. Irritant contact dermatitis, the more common type, is direct damage to the skin from a chemical or physical exposure. Think of a healthcare worker's hands that are raw from constant washing and sanitizing. There's no allergy involved, it's simply injury to the skin barrier. Allergic contact dermatitis is different. It's a delayed immune reaction driven by T cells in someone who has become sensitized to a specific allergen. Classic examples are nickel in jewelry and the oil from poison ivy. The rash shows up a day or two after exposure and appears where the allergen touched the skin. There's also atopic dermatitis, the chronic, often inherited form of eczema seen in patients with allergies and asthma. For you as a medical assistant, the most valuable thing you do here is history. Ask what's new: new soap, new detergent, new jewelry, new plants, new gloves. Then reinforce the plan. Avoid the trigger, keep the skin moisturized, and use medication as directed. Next is acne vulgaris, the most common skin disease in the country and one nearly every patient has dealt with. Acne is a chronic inflammatory disease of the pilosebaceous unit, which is the hair follicle together with its attached sebaceous or oil gland. Remember that unit from Lecture 1. The cards on the right walk through the four drivers that combine to produce acne. 1. Excess sebum, driven mainly by androgen hormones, which is why acne flares at puberty. 2. The follicle gets plugged when skin cells lining it build up and don't shed normally. That's hyperkeratinization. 3. A normal skin bacterium, Cutibacterium acnes, that's a funny name because it's not really cute when you have acne, is it? But anyway, I digress. That bacteria overgrows in that oily plugged environment. And 4, the follicle becomes inflamed. Those 4 steps explain every acne lesion. A plugged follicle is a comedone. Open ones are blackheads, closed ones are whiteheads. When inflammation takes over, you get papules and pustules, the red bumps and pus-filled spots, and in severe cases, deeper nodules and cysts, which can scar. Acne shows up on the face, chest, and back, where oil glands are densest. Your role is coaching. Treatments take weeks, so patients quit too early. Teach a simple, consistent routine, emphasizing sticking with it, and steer them away from picking or squeezing, which worsens inflammation and scarring. Pressure injuries, which were formerly called pressure ulcers or bed sores, are localized damage to the skin and underlying tissues from prolonged pressure, usually over a bony prominence like the sacrum, heels, or hips. They're common, costly, and largely preventable, which is exactly why your role matters so much. We describe them by stage based on depth, and here's where Lecture 1's layers pay off. Stage 1 is intact skin with non-blanchable redness. Press on it and the redness doesn't fade. Stage 2 is partial thickness loss. The epidermis is gone and you see shallow, pink, moist dermis, sometimes as an intact or open blister. Stage 3 is full thickness loss extending into the subcutaneous fat. Stage 4 is the deepest, full thickness loss with muscle, tendon, or bone exposed. 2 special categories don't get a number. Unstageable means the base is covered by dead tissue. Slough or eschar, so you can't see how deep it goes. It's staged once that tissue is removed. Deep tissue pressure injury shows as a persistent maroon or purple area, with skin that may still be intact or blistered, signaling damage underneath. Your role on the green bar: reposition roughly every 2 hours, offload pressure with cushioning and support surfaces, use a risk tool like the Braden scale, and document and photograph carefully. Note that we don't reverse stage as a wound heals, and remember these injuries can develop under medical devices too. Our fourth condition, cellulitis, is the most urgent of the group, so pay close attention. Cellulitis is an acute bacterial infection of the deeper skin, the deep dermis, and the subcutaneous tissue beneath it. It's extremely common, with millions of cases a year in the United States. It's usually caused by two bacteria, Streptococcus pyogenes, or group A strep, and Staphylococcus aureus. The bacteria get in through a break in the skin, cut, an insect bite, a chronic ulcer, a surgical wound, things like that, which is one more reason skin integrity and wound care matter. Clinically, cellulitis looks like a warm, red, swollen, tender area with edges that are poorly defined and spreading, and patients often run a fever. Now look at the red card on the right, because this is the part that protects patients. Escalate promptly. Get the provider. If the redness is spreading quickly, if the pain seems far worse than the skin looks, if there's a high fever, or if you see red streaking running away from the area. Pain out of proportion, in particular, can signal a rare but life-threatening deep infection called necrotizing fasciitis, which is a true emergency. As a medical assistant, a simple, powerful habit is to outline the border of the redness with a skin-safe marker and note the time. If the redness marches past that line, everyone can see that the infection is advancing. Recognize, mark, document, and escalate. This slide is the one I most want you to take to heart because catching skin cancer early saves lives, and you are often the first person to see the patient's skin. There are three main types. Basal cell carcinoma on the left is the most common. It arises from the basal cells at the bottom of the epidermis and classically looks like a pearly or waxy bump on the sun-exposed skin, such as the face. The good news is that it grows locally and rarely spreads to other parts of the body. Squamous cell carcinoma in the middle is the second most common. It comes from the keratinocytes, the squamous cells, and often shows up as a scaly, crusted spot or a sore that won't heal. Unlike basal cell, it can spread if it's left untreated. Melanoma on the right is less common, but by far the most dangerous because it accounts for most skin cancer deaths. It arises from the melanocytes, the pigment cells, so it tends to look like an irregular, dark, or multicolored mole, and it can spread early. That's why early detection is everything. The common thread across all three is ultraviolet or UV damage to the DNA and skin cells, which means skin cancer is largely preventable with sun protection. The pink bar is the ABCDE checklist for spotting a suspicious mole. Asymmetry. This means that one half doesn't match the other. Border. Irregular or ragged edges. Color. More than one color or shades of color. Diameter, larger than a pencil eraser, about 6 millimeters, and evolving, any change in size, shape, or color. Diagnosis is confirmed with a biopsy. Your role on the green bar, teach sun protection and monthly self-exams, help set up and assist with skin checks and biopsies, and document and flag any suspicious or changing lesion so the provider can evaluate it. You as the MA never diagnose, but a good catch and a clear note can change everything. Once we can recognize these conditions, how do we assess and confirm them? Three core diagnostics, and all three sit squarely within your scope. First, the visual skin assessment. This is the foundation. You inspect the skin systematically for color, integrity, any lesions, moisture, and temperature, and you note the exact location. Describe precisely what you see: size, shape, color, drainage, because your written observation is frequently the very first clue the provider has. Second, wound measurement. When there's an open wound, we measure it in centimeters, length by width by depth. We also check for undermining or tunneling, where the wound extends under the skin edges or bores in one direction, and we measure at each visit so we can track whether it's healing or worsening. Consistent measurement and photography per your facility's policy make that trend visible. Third, skin culture. When infection is suspected, we swab the wound to grow and identify the organism, bacterial or fungal, and to get sensitivities, which tell the provider exactly which antibiotic will work. Your part is proper technique. Collect from the right spot, label accurately, and handle and transport the specimen correctly so the result is reliable. Notice the theme: observe carefully, measure objectively, and collect specimens cleanly. Those three skills drive the whole diagnostic picture. Now for the pharmacology and treatments. Four main medication classes cover the conditions we've discussed, and understanding what each class does makes the medication list on the next slide make sense. First, topical corticosteroids. Steroid creams and ointments that calm inflammation and itching. These are the workhorses for dermatitis. Hydrocortisone is the mild, over-the-counter one. Triamcinolone is a stronger prescription. Second, antibiotics, which treat bacterial infections. They come as topicals like mupirocin for small skin infections and orals like cephalexin for cellulitis. Some, like doxycycline, are also used for their effect on acne. Third, antifungals for fungal infections of the skin and nails. Clotrimazole for athlete's foot and ringworm. Terbinafine for stubborn nail infections. And fourth, the acne agents. These work in two ways. Retinoids like tretinoin unclog the follicle by normalizing how the skin sheds, and benzoyl peroxide kills the C. acnes bacteria. They map directly onto the four drivers of acne we saw earlier. Keep these four categories in mind: steroids, antibiotics, antifungals, and acne agents as we look at the specific drugs. Here's the medication table for the integumentary system: the common trade names, their generic names, what each one does. You don't need to memorize every detail, but you should recognize these names on a chart and know which category each belongs to. You should also practice pronouncing them. The first two are topical steroids for dermatitis: cortisone 10, which is hydrocortisone, and Kenalog, which is triamcinolone. The next three are antibiotics. Bactroban, which is mupirocin, is a topical antibiotic for small skin infections. Keflex, known as cephalexin, is an oral antibiotic commonly used for cellulitis. Vibramycin, known as doxycycline, is an oral antibiotic that's also used for acne. Then two antifungals: Lotrimin, which is clotrimazole, and Lamisil, which is terbinafine, especially for nail infections. And finally, the two acne agents that map to the drivers we discussed: Retin A, tretinoin, a retinoid that unclogs the follicle, and panoxyl, which is benzoyl peroxide that kills acne bacteria. One practical note shown at the top: each drug is listed under one representative brand, but most are sold under other brand names and as generics. So the same generic may appear on a chart under a different label. When you room a patient, knowing both names helps you reconcile their medication list accurately. So let's bring it all together in a summary. Here are 6 takeaways mapping to today's outcomes. 1. The common conditions. Dermatitis is inflammation. Acne is a disease of the pilosebaceous unit. Pressure injuries are defined by depth. And cellulitis is a bacterial infection of the deeper skin. 2. The 3 skin cancers. Basal cell carcinoma, the most common. Squamous cell carcinoma. And melanoma, the most dangerous. UV damage is the main risk, and ABCDE is your tool for spotting a suspicious mole. 3. Pressure injuries are staged 1 through 4, plus unstageable and deep tissue injury. And cellulitis can turn serious, so know the red flags and escalate. 4. The core diagnostics. A careful visual assessment, wound measurement in 3 dimensions, skin culture for infection, and biopsy for suspected cancer. 5. 4 medication classes: topical steroids, antibiotics, antifungals, and acne agents. Cover the treatments, and you should recognize the common trade and generic names and know how to pronounce them. And 6, your role runs through all of it. Recognize and document, measure wounds, collect clean specimens, educate patients on sun safety and adherence, and escalate the moment something looks dangerous. That completes the pathophysiology, diagnostics, and pharmacology of the skin. In the next lecture, we'll focus entirely on the medical assistant's hands-on role. Review the vocabulary and the medication table before then. Need more info on the information in this lecture? Go ahead and check out the references I have listed here.